to this webinar. The first one was oversubscribed, so we are rerunning it. We're so glad that you could attend. As Mary said, this is our WATES webinar, which is What Are the Experts Saying? And today we'll be focusing on 2015 Year in Review for Health Law. Again, my name is Jenna Ellis. I am one of your moderators along with my co-moderator, Dan Titello. And if you have any questions for our experts, or if any questions come up during the webinar, please also feel free to use the chat feature on your menu bar, and we'll go over questions at the end of the presentation today. So feel free to do that during the webinar, and then we'll follow up at the end with any questions. So with that, I wanted to present and introduce our expert today. Kelly Rooney is an Associate Managing Editor at the Health Law editorial team of Wolters Kluwer Legal and Regulatory Solutions. Hi, and welcome, Kelly.
Hi, glad to be here.
So Kelly wrote a great white paper, and as Mary said, that you can download that if you haven't already done it with the attachment tab on the menu bar. And it went over 10 really important health law topics from 2015. We're going to pull some of those out and discuss them and talk about several, actually 5 of them today. Let's see, Dan, I think there's an overview. We'll pull that up. And so the first one that we really want to get to is cybersecurity. And cybersecurity is pretty constantly and consistently in the news. Kelly, why do hackers care about health records?
Right. It's a really scary issue right now. It's not just the underlying health information that these hackers are after from health records. It's information like names, addresses, social security numbers that really make these health records prime targets for data breaches. This personally identifiable information can be used for identity theft, or if the hackers are able to ascertain underlying medical diagnoses, health conditions from electronic health records, they could use that to file fraudulent Medicare or insurance claims for services or equipment in your name.
In 2015, we saw some significant breaches.
Definitely. We hear a lot about these data breaches when it comes to retailers and banks, but insurance companies and hospital systems are certainly subject to a lot of data breaches as well. In February of 2015, Anthem, which is the second largest health insurance company in the United States, had a data breach where 79 million people were affected, and information like birth dates, social security numbers, and employment data was obtained. Another insurance company, Primera, was breached back in March of 2015, which affected 11 million health records. But like I said, it's not just insurance companies. The UCLA health system had a cyber attack back in August where 4.5 million individuals' protected health information may have been compromised. As a result of this UCLA health breach, a class action lawsuit was filed claiming that the data should have been encrypted. Although the case has since been dismissed, a monitoring system was put in place as a result of the cyber attack.
Okay, so you mentioned the class action, but what else, or why are providers, why should they care about these breaches?
Well, not only are these insurance companies or hospitals subject to things like bad publicity or loss of business as a result of a data breach, but these breaches cost an enormous amount of money. Having health information breached violates privacy and security rules of HIPAA. So covered entities and business associates under HIPAA must not only comply with breach notification requirements in the event of a breach, but they're also subject to civil monetary penalties as well. These penalties now are actually tiered in terms of culpability. So even seemingly innocent companies where the HIPAA violation may have had a reasonable cause and wasn't due to willful neglect on their part, even those entities are liable for civil monetary penalties.
So when we look at those penalties, what are providers doing and what can they do to guard their information?
There are a couple of safeguards that are recommended by the Office of Civil Rights. The OCR is an HHS entity that enforces HIPAA, privacy, security, and breach notification rules, as well as the Office of the National Coordinator for Health Information Technology, or the ONC. Now, these are both recommended ways to protect against a data breach. One of them is data encryption. This is said to be the most basic and easy way to protect yourself from a breach because it actually encodes data so that only authorized people can read it. Now, this is what the class was arguing should have been done in the UCLA health system case. Also, another method that makes it harder to access data is this two-factor authentication. This is a recommendation by the ONC, which actually means having more than one authorization required in order to access data. So an example of this would be if you're required to enter a fingerprint scan as well as a passcode to access a system, or scan a security badge as well as entering a passcode. But to be clear, neither of these safeguards are explicitly required, but they certainly are good practice.
And when we look at cybersecurity in 2015, the government has really responded, I think, or tried to, with the Cybersecurity Act of 2015.
Right. They certainly are trying to respond to the cybersecurity issue. The Consolidated Appropriations Act of 2016, which was signed by President Obama back in December, in part established the Cybersecurity Act of 2015. This is really meant to stop cybersecurity threats and breaches before they even occur. It establishes a voluntary information sharing network which allows private companies to share any cyber threat indicators or defensive measures with the federal government. And in exchange, these private entities are granted liability protection from sharing that information. But since cybersecurity is really still an emerging issue, best practices on how best to protect against these threats are really still being established. The President presented back in early February the proposed budget for 2017. This included $20 billion earmarked for dealing with cybersecurity. So we should see more about this going forward in 2016. Also, the OCR, which again enforces HIPAA, privacy, security, and breach notification rules, is expected to launch the next phase of its audit process early this year. Under the HITECH Act, which was passed in 2009, the OCR is required to put into place a permanent audit process, which has not yet been done. So in the meantime, entities, insurance companies, hospitals really should make sure that they're documenting any actions that they're taking with regard to cybersecurity. Make sure that if they are putting breach notification processes, for example, into place, that they're documenting that very well, just in case they are audited down the road.
Okay, great. So I want to move to our next topic to review from 2015, and that next topic is contraceptive coverage.
Right, and providing no-cost contraception coverage through employee health plans has not surprisingly been very controversial. So back in 2014, we saw the Hobby Lobby case wind up before the Supreme Court. That was where a private for-profit corporation was arguing that the requirement to provide contraception coverage to its employees violated the Religious Freedom Restoration Act, or the RFRA. The court agreed in Hobby Lobby and said that these closely held for-profit entities should be granted an accommodation from the requirement if it violates their religious beliefs. Right after that Hobby Lobby ruling, the government came out with this EBSA Form 700. So organizations wishing to request an accommodation from the contraception coverage requirement would have to file it with the government. Now, filing this EBSA Form 700 essentially shifts the responsibility to provide the coverage from the employer to the employer's insurance provider. Then, in July 2015, we saw a final rule come down that further explained the opt-out accommodation and further defined what an eligible organization is for the purposes of this accommodation. Under that definition, both closely held for-profit corporations that meet certain requirements, like Hobby Lobby, as well as nonprofit religious organizations, are required to file this EBSA Form 700 in order to receive an accommodation.
Okay, so there's a lot of, we know kind of about Hobby Lobby, but there's also a lot of current cases that reference Form 700, EBSA Form 700, and we're kind of collectively referring to them as Zubek.
Right. So the Zubek versus Burwell case is actually a consolidated group of cases all brought by religious nonprofits that are arguing that even the act of filling out this form to opt out of the contraception coverage requirement is a substantial burden on their religious exercise. They're saying that the accommodation process requires them to play a role in the facilitation of contraception use by their employees. Now, 8 separate circuits have rejected this argument. Only the 8th Circuit has found that the opt-out provision violates the RFRA.
And I think oral arguments are going to be heard this month, right?
Right. So oral arguments are set for March 23rd. We expect that the decision will be out at the end of the term, probably late June.
And so how does the death of Justice Scalia factor into this?
It certainly has, veiled the Supreme Court with a lot of uncertainty. What we can say is that a new justice is not going to be in place before the oral arguments on March 23rd. That's only 3 weeks away. What that means is that it's very likely the decision is going to end up in a 4-4 split. So in the case of a tie, the decisions of each of the circuits will stand. We might see, as a result of this turmoil, the circuits that have yet to rule on the contraception mandate might rush to do so, knowing that whatever they decide will be upheld in the event of a tie. Just recently, the 11th Circuit issued 2 rulings in favor of the government. But even still, Zubik aside, there's other new challenges that are coming up through the courts to the contraception mandate. So really, even next year, once a new justice is in place, the court might have another chance to rule on the contraception mandate.
Okay. And another topic that I want to talk about also had, a big Supreme Court case involved with it, and that is the health insurance exchanges.
Right. Another major goal of the ACA was to provide tax subsidies to individuals meeting income requirements in order to purchase coverage on health insurance exchanges. At the end of last year's Supreme Court term, we were anxiously awaiting then the decision in King v. Burwell. Now, that involved a challenge to ACA Section 1401 that says that individuals are provided premium tax credits if they enroll through an exchange established by the state. Now, King was arguing in that case that because the government was providing these tax credits to purchasers on all exchanges and not just those that were established by the state, that the subsidies provided to them for purchasing on the federal exchange or healthcare.gov were illegal. But the court ultimately found, however, that the intent was to provide these tax credits whether or not states had established their own exchange.
So then, Kelly, where did 2015 leave us statewide?
Right. So this map really shows that states are falling into 4 different categories at this point with regard to the status of health insurance exchanges within them. Traditionally, there were only 3 different categories. The first being a state-based exchange. Now, that's where all elements of the exchange, including the exchange website or platform on which the residents are purchasing the health insurance coverage, is maintained directly by the state. The second category are federally facilitated states. Now, those are states that decided not to establish their own exchange and instead are entirely using the federal exchange, which is healthcare.gov. And the third category that we were traditionally seeing were states that have a partnership with the federal government. So those states may be administering some of the services itself, like consumer assistance, but they leave the rest up to HHS. So the actual insurance is purchased on the healthcare.gov platform. Now we're seeing this fourth category emerging. So we're kind of calling these hybrid states. Others you might hear in the news referred to as federally supported state-based exchanges. These are states that previously maintained a state-based exchange. We're seeing that maybe due to technical difficulties, for example, maintaining their platform, they've decided that they're no longer going to have a straight state-based exchange. So they might handle all of the exchange functions except the IT platform and instead use healthcare.gov. So we're seeing states like Oregon and Hawaii, for example, falling under this hybrid category.
Well, and it seems like there's probably a political element, to this. And in 2016, a lot of changes based on, changes of administration.
Right. We may see going forward in 2016, if new governors don't want to toe the Obamacare line, they might just opt to switch to a federally facilitated exchange instead of a state-based one. Kentucky, it's interesting to note, had long been considered sort of the golden child on the state-based exchange front. That state enrolled a ton of people because it had a very aggressive media campaign, easy-to-use website and mobile app, and they brought their uninsured rate down to 9% because of the state-based exchange. But now the new Republican governor, Matt Bevin, took office, and he said that he's going to dismantle the state-based exchange. He went to CMS and told them that, and CMS is coming back to Bevin telling him that, well, we'll work with you to transition to a federally facilitated marketplace, but that grant money that was awarded to Kentucky in order to establish the state-based exchange is now going to be closed out. But aside from these political reasons, there may be other reasons for changes at the state level. The decision in King v. Burwell really made it so it no longer matters from a tax credit standpoint whether a state is maintaining its own exchange or not. So if any technical difficulties come up, a state might just toss aside the state-based exchange and go with a federally facilitated exchange instead.
Okay. So a separate but related topic that we hear a lot about when we talk about these exchanges is Medicaid expansion.
To remind everybody what this is about, the ACA provides for the expansion of Medicaid eligibility to adults with household incomes up to 133% of the federal poverty line and that aren't otherwise eligible for other assistance. States receive financial assistance from the government for expanding Medicaid under the ACA, but they're not penalized for not doing so. As of January 2016, 31 states and the District of Columbia have expanded or are in the process of doing so. In January, we saw the new Louisiana Governor John Bel Edwards announce his intent to expand Medicaid in Louisiana after his predecessor, Bobby Jindal, had adamantly refused to do so during his term. Obama even visited Louisiana following Edwards' announcement, hoping that some other red states might follow Louisiana's lead. We've seen a little bit of movement in Idaho, in Utah, as far as possibly expanding Medicaid soon. But meanwhile, in Kentucky, the new governor, Matt Bevin, is calling to repeal the state's Medicaid expansion as well as the state-based exchange. So not surprisingly, states holding out on Medicaid expansion is largely political. But if a governor suspects that a plan isn't going to get support in the legislature, it's possible that they could still expand. Some states in 2015 had success expanding Medicaid under a Section 1115 waiver.
So what is a Section 1115 waiver?
It's nothing new. A provision of the Social Security Act. This has been around since Medicaid was established in the 1960s. It really provides HHS with the authority to grant states a waiver to design or improve their Medicaid program, so they could use this to expand services that are provided to all or some of the Medicaid population in their state, or in this case, expand eligibility for the program in general. It's up to HHS to approve these waiver requests, but we saw in 2015, Pennsylvania, Montana, Arkansas all expand Medicaid under Section 1115 waivers.
So are we watching the 1115 waiver expansion in 2016?
Yes, definitely. I do think more states are probably going to jump on the bandwagon and expand Medicaid, because really it's only hurting their constituents if they don't. But I do think, given the political landscape, the fact that it's an election year, these states are probably going to use a Section 1115 waiver to expand rather than the traditional ACA expansion. But 2016 is the last year for the full, meaning 100% federal financial participation. After 2016, the FFP will gradually decrease every year until 2020. States are left receiving only 90% funding from the government, so they'll have to foot the bill for the other 10%. So really, it's in their best interest to expand this year if they plan to do so under the ACA.
So our next topic and last topic has been around really for years, and it's a particular interest for our attendees who follow reimbursement issues, and it's sustainable growth rate.
Right. So like you said, it's been around since the 1990s, actually, and this was meant to counter the inflationary growth in Medicare physician payments that was recognized at that time. So in 1997, the SGR was passed, and 4 years later, it went into effect. So that year, it was supposed to result in a 4.4% reduction in physician payments. But Congress actually acted very quickly to pass the first of what have now become called doc fixes. So this is legislation that balanced out that payment reduction under the SGR with instead a modest payment increase. Ever since, every year when the expiration date of a doc fix approaches, Congress has pushed back the SGR payment reductions, and it has extended it for another period of time. Hospitals, physicians, interest groups have long clamored for the repeal of the SGR. Finally, in 2015, through the passage of the Medicare Access and CHIP Reauthorization Act, or MACRA, the SGR was repealed. So MACRA, which was passed on April 16th of 2015, had the effect of repealing the SGR formula, but it also made changes to the Medicare physician payment methodology. It ties payment a little more to value than it had been before. Some of the initiatives under MACRA are nothing new, really. They've existed in provisions of the ACA, and even before the passage of the ACA and other payment systems. So specifically, MACRA includes payment incentives for example, physicians that work to coordinate care, improve quality, and reduce costs. That's part of what MACRA calls the alternative payment model, or the APM. MACRA also establishes what's called the merit-based incentive payment system, or MIP, which provides incentives to providers if their performance meets some pre-established performance and quality standards.
So have we heard anything about MACRA and about who physicians groups or medical groups, any comments about this?
Really, the feelings of these physicians, hospitals, and interest groups are yet to be seen. We really are hearing from, so far, the American Medical Association, the American Hospital Association, for example, that they're happy that the SGR was repealed, but they're not quite sure about these changes that the MACRA makes to payment methodology and incentive payments under MACRA being tied to performance and quality. Quality has historically been very hard to measure, and whether other payments initiatives and measures in the past were successful is really a subjective question. So certainly we can expect these groups, these physicians, hospitals, interest groups like the AMA and the AHA being very vocal about their feelings on MACRA, just like they were on the SGR for the last 20 years.
Okay. Okay, great. Thank you, Kelly. Dan, I will let you look over our questions to see if we have any. And while you're doing that, I'm going to quickly say some of the questions we're asking about the slides. You can download the slides and the white paper in the Handouts tab. Also, you'll be getting an email with the slides as well as the links. We've done some WATES webinars in 2015 specifically on some of these like King v. Burwell, some of the topics that we discussed today. We did a full webinar about them. So if you are interested in that, you can use the links that we will send to you with the slides. And also in the email, there'll be a really, really short survey. That survey helps us determine exactly what topics you're interested in. So it would be great. It's literally 5 questions. So it would be great if you could complete that survey. We'd appreciate it. Dan, any questions from the attendees?
I think everything, no, there's no questions we didn't answer. I think we're good.
Okay. All right, sounds good. Well, thank you so much, Kelly. We appreciate it, and thank you to everyone who attended. Thanks, Kelly.
My pleasure. Thank you.
Bye, everyone.
Thanks, everybody.